Good afternoon, everyone. I'm Dr. Alvin Marcelo. I'm from the Asia eHealth Information Network and the UP Manila Standards and Interoperability Lab. Good afternoon, good morning, good evening, everyone. This is also a presentation of the open source working group of the International Medical Informatics Association. So without further ado, I'd like to call our convener in the open source working group, Professor Shinji Kobayashi. Professor Shinji, do you want to say something?
Oh, okay. Thank you for giving us such a chance to make a presentation for our work and open source software and open source AI for healthcare. Good afternoon, everyone. I'm Shinji Kobayashi from Gifu University, and I currently serve as chair of the open source working group. My role today is give a short framing what we mean by open source, how the IMEA working group has approached open source in health, and why this discussion has become especially important in the era of AI. Okay, next slide. Before talking about the working group, I want to start with one word, open source. Open source is not simply software that is free of charge. It is a set of permissions for freedoms. Uh, use Can we use it for any purpose? And study. Can we study how it works by its source codes? And can we modify it for local needs? And share? Can we share it with or without changes? These four freedoms come from the free software and open source traditions, which we bring together here under the term FOSS. This distinction matters for today's webinar. Open source is not the same as source available, and the AI context, open source is not the same as open weights. That will become important later. Okay. Open source is as a digital public good. A second framing is digital public goods. The UN and the digital public goods community use this concept for open source software, data, AI systems, standards, and content that support the sustainable development goals, protect privacy, and do no harm. In health, many familiar tools are part of this ecosystem. Uh, Digital public good, DHIS2, OpenMRS, OpenCRVS, OpenIMS, and GNU Health. The important point that the digital public goods are not just isolated software projects. They can become a part of digital public infrastructure for health systems. Infrastructure for health systems. That means reusable, inspectable, uh, and adaptive infrastructure rather than permanent dependence or rented platforms. For software digital public goods, uh, open source licenses is essential. The DPG standard requires approved open source licenses and open source software. This means OSI approved licenses. The IMEA Open Source Working Group was established in 2002. IMEA is the International Medical Informatics Association. The working group exists to disseminate knowledge about benefits of FOSS in health, provide a neutral platform for stakeholders, foster collaboration between projects, and lower the barrier to real-world adoption. We are not vendor and not the product community. We are a meeting place. That neutrality is important because open source in health is not only about software development, it is also a procurement, sustainability, and governance, local capacity, and equity. The working group's work is a trajectory, not a snapshot. We started from open collaboration and FOSS as a model. We then move into open data, including privacy, security, and data governance. In 2019, Chris Patton and I discussed open science and approach and AI in healthcare. Open data, open tools, open research, and open educational resources as a response to black box AI. During COVID-19 pandemic and infodemic, the importance of open source, open data, and civic technology became even clearer. Then 2022, we discussed open source digital health software as a foundation for resilient, accessible, and equitable health systems. The key message is this. Open source is a broader frame. Open data and open source two operational foundations of AI. Most of AI framework is built on open source software and they learned from open data. But in health, open data does not mean publishing patient records directly. It means responsible data governance, metadata standards, and provenance content, privacy protection, and safe reuse. Why this matters in Asia and AeHIN? I think there are four stakes that this region has raised for many years. First, equity. Can countries run and adapt and afford system on their own terms? Second, sovereignty. Can health systems control their data and their technical stacks? Third, digital public goods. Can we build shared infrastructure rather than rented dependence? And fourth, capacity. Can we develop local engineers and informaticians who can study and modify systems, not just consume them? Open source is one of the few approaches that can speak to all the four. In the AI era, the question is whether health system in the AI era, the question is whether health systems remain consumers of AI or become governors of AI. Now we come to the key questions. Does the open source yardsticks survive AI? I think the answer is yes. But the yardsticks must be extended. International software to source code source code is central, but AI systems are part of uh, part part code, part data, and part model and parameters. This is why open source AI definition OSID is useful. It keeps the same for freedoms, use, study, modify, and share. But for machine learning systems, it also asks for data information, code, and parameters. In other words, open weights uh, alone are not enough. This is especially important in healthcare. Uh, patient level training data often cannot and should not openly released. But we still need enough information about data, provided data provenance, processing, and evaluation, also, and model parameters to inspect biases uh, on rented uh, reproduced methods and adapt systems locally. So OS AID is not medical safety standard. It does not assure the AI system is clinically valid or safe, but it gives us a starting point for asking whether system is meaningfully open enough to be audited, adapted, and governed. This discussion is also very timely. UN Open Source Weeks is taking place in this week at the United Nations headquarters in New York from the July 22 to 26. And today, June 23, the official focus the official focus is official focus is open source and AI. This is exactly question we are discussing discuss here, how open source can support responsible AI and bridge digital device and build local capacity. So this AeHIN discussion is not isolated. It's a it is part of wider global conversation happening right now. With that framing, uh, I would like to hand over Chris, who discuss equitable health AI and AI on the edge of rather than, and then AI Alvin, who will take us toward practical checklist. The question is not whether health system will use AI. That will. The question is whether they can inspect, uh, adapt, and govern it. That is why open source matters. Chris, over to you. Okay.
Okay, hello everybody.
Hello, everybody.
Hopefully everyone can hear. My name's Chris Payton. I'm an associate professor at the Liggins Institute at the University of Auckland in New Zealand, and I've been working with the IMEA open source working group for quite a few years with Shinji, as he said. So please do go and have a read of our papers. about open source software in healthcare. We also do workshops at the various conferences like MedInfo and things like that, so people can come along to those. So today I'm just going to talk a bit about some trends in digital health and AI, and how open source and on device might help with some of these trends. So I'll just start off with so the trends I'm going to talk about are agentic AI, the AI bubble and the backlash that's going on, open weights and on-device models, um, a bit about scientific evaluation, a bit about regulation. So agentic AI, there's kind of two meanings of agentic AI. So software agents really are agents that can use tools, but there's been some development of this kind of term of agentic AI recently. I think it was Ilya Sutskever who predicted that agentic AI was going to take over everything a couple of years ago, and he was quite right. So the first one, which everyone will be familiar with, is coding agents. So I think this is a video. So this is just showing like how you can use a coding system like Claude, and it will use agents. So Claude itself is kind of an agent because it can use tools, but also it uses and coordinates like sub-agents. And so one of the initial uses of agents was to get out, and this is what Ilya Sutskever was talking about, is to get over the problems of the limited context window. So if you've got lots of large language models working in a coordinated fashion, they can deal with a lot more context than one agent working on its own. So one agent working on its own, once it hits its context window limit, it will have catastrophic forgetting. So it will start forgetting what it was working on. But if you have lots of sub-agents controlled by a main agent, it will they can all report back, and it can kind of keep control of everything. So this task I asked it to do was a literature review of AI in primary care, and basically use the Claude Deep Research skill, and this enables it to plan out doing some research into phases, and then for each phase spawning sub-agents to go and do work. So the first thing was to work on the scope, and it just used one agent to do that. And then it started doing searches, and it's using 5 agents to search for the literature. Um, then it then it starts fetching research articles, and it's starting to use 26 agents to do that. And then it's checking the content of all the articles, and it's using 75 agents to do that. So you're getting up to 100 agents just all spawned from one prompt, and then it comes back and it will synthesize. And so this whole thing ran for 25 minutes. Um, it did quite a good job. It did report on some of what I would say were the main findings and main studies in this area. But I did tell it to do a systematic review and to use the Prisma guidelines, and it didn't do either of those, although it did acknowledge that it didn't do that. So it was a bit dishonest, but then it acknowledged the problems it had. So that's one way of using agents. And as coding agents, these systems are getting better all the time. And the latest models are getting up to be almost as good as software engineers, according to the software engineering benchmark. And improving rapidly is the other thing. So it was only like a year or so ago that they were not very good at doing this, and now they're very good. Then the other use of the term agent is these kind of personal AI agents. Um, Kind of OpenClaw was the first kind of major one. So OpenClaw is an open source project that was designed to use your AI subscription, so your ChatGPT or your Claude subscription, but act as a personal AI that has agency. So it can access you can tell it what you give it access to, but essentially runs in a loop and makes notes about what it's doing. So it's basically a harness to enable an AI to run and not run out of context. And people have been using it for managing their emails and helping them with their business activities and things like that. And quite often you just chat to it using WhatsApp or Telegram. So it all seemed a bit of a joke when it first started. And people were quite concerned about it from privacy security problems. But it was bought by OpenAI recently, and NVIDIA have got a version of it called Nemo Claw. And at the Microsoft Build conference recently, they announced that they're building it into Windows. It's a Microsoft app. So these kind of personal AI agents, that's the other kind of meaning of the agentic AI terms that's being talked about at the moment. Okay, the next trend is the AI bubble and the backlash. So um, one of the issues with large language models is because they essentially copy the text from the training data into the model, and that's how they kind of provide the kind of answers that you want when you're talking to them. The way that they improve is by copying more source data, more training data into the model. And this requires bigger and bigger models, and I'll mention one of the open weights models in a minute. But we're getting up to 1 trillion parameter models now, and these require very hefty hardware in the data centers and new chips, which is meaning that these companies are having to build out massive data centers very quickly, which means they're spending huge amounts of money on this. The main recipient of the money is NVIDIA, and although many of the data centers have not been built yet, the companies have reserved orders of chips. So they're basically spending the money on chips, and this is in the order of like $100 billion type of investments. So lots of people say this is not really sustainable. These companies are not making a profit, but they're spending $100 billion and predicted to spend more. And the reason they're doing this is because to be the best model, you essentially have to be a bigger model. And there's this idea of scaling laws. So you have to use the latest chips from NVIDIA because they can run the big models and they can run agentic harnesses with the big models. And there's like an arms race to be the biggest model. So this is the latest hardware from NVIDIA. It's called the Vera Rubin chip. So they name them after kind of scientists. And Vera is the CPU and Rubin is the GPU. And this is what they call their AI factory platform, which is this huge racks of GPUs and CPUs and storage and switches. And this is what's going into the new data centers that are being built out by Microsoft and Meta and people. They're also planning on doing space-based data centers, which seems to me to be quite a strange idea. I don't think it's necessarily going to work, and maybe a bit, attention grabbing rather than realistic. But a lot of there's been, especially in the US, it's not so much in New Zealand, Australia, and Asia, but in the US, there's been a big backlash against data centers, and lots of governments and states are saying that they're not allowed to build data centers. So going up into space was like the answer to that. So people are now looking at, how cost effective is AI really? Lots of companies now are looking at how much is being spent on buying tokens and are scaling back their AI investments. And the way that the finances have been set up means that people are very concerned about the stock market. So SpaceX went public last week, I think, and they went up a bit, but then I was just looking today and they've just dropped 10%. So we'll see whether that's the beginning of the end. Like famous investors like Michael Burry have predicted that this is the beginning of a financial crash caused by AI overinvestment. The other thing is I kind of mentioned about the US. Public sentiment's generally kind of switched from favorable to unfavorable towards AI over the last few years. And in healthcare, NHS, this is in the UK, NHS staff have much more positive about AI than the public. So that's something to think about as well. One kind of measure of sentiment is these commencement speeches we've probably all seen on social media, where AI executives get booed by the students who are worried about job losses and AI in general. I think that's quite a US thing. Okay, so I think some of the kind of challenges here can be addressed by using open source and on-device AI. And at the Microsoft Build conference a couple of weeks ago, Microsoft announced a whole range of new hardware. They really seem to have pivoted to on-device. They haven't really got the hardware out yet, and it does mostly use NVIDIA technology under the lid. But they're getting even laptops which will run local models, designed to run local models, but it also just kind of normal desktops designed to run local models. Dell have had a couple of models out for a little while now. One is the GB300 and one is the GB10. So the GB300 can run a 700 a 700 billion parameter model, whereas the GB10 can run probably a 70 billion parameter model. And with quantization, which we can talk about if people want to, you can run big models on less hardware. And it does seem like even going down to 1-bit quantization, you can still run models and it gets it to do software engineering tasks. So that's quite interesting. So I think the trend is really that the hardware is coming down the line quite quickly, and a lot of hardware people are and Apple as well will be doing this, designing machines that can run models locally. The other is the open weight models. So Sinji talked a bit about the difference between open source and open weight. So most of the models that you can download onto your own computer are open weight, which means that the weights have got an open source license, like MIT license for the weights. They don't normally tell you what the training data was or how they train the models. So then the code is not open like an open source project, but the weights, basically it's just the weights are just a file with numbers in it, and they open source that, so you can look at the numbers if you want to. They don't really mean anything, and you can use it however you want according to the license, and you can run it on your own model. One thing that you can do with open weight models, which is quite good, and I've been working on the Llama model, particularly the 70B model that I've been running on my GB Dell. I've got one of these Dell GB10s, and that is to fine tune them or kind of retrain them with your own data, or to be better at different tasks. And that's quite an exciting development that could be quite useful for healthcare. So, what can you do in healthcare with open weight models running on device, and why would you want to do that? So this is the patient agent idea. So this is a patient's own device. So although you can't run very good models on mobile phones at the moment, that's probably going to change fairly quickly, I would say, within the next 6 months. You'll be able to run an on-device open weight model on your phone. That means that the agent you can chat to it, you can do voice chat with it. You could have your own secure records on the device, not on the internet. It can access your sensor data like your blood pressure, your heart rate, your activity, and works in an agentic way. So you can ask it to monitor things and to, connect with the hospital or the clinic if needed. and share the kind of data that you are happy with being shared. And that's all enabled by these kind of open weight models and the advances in the GPU technology. From the doctor's point of view at the clinic, they can run perhaps a more powerful computer, perhaps like the GB10 or the GB300, and again use an agentic system that can look after all the records for the practice, but storing them on the computer, not in the cloud, and then using a larger open weight model on the computer. And one of the things you would be able to do with this is if a patient comes in with their on-device model on their phone, for example, they could communicate with each other, the two agents. So one of the things about agents is that they can chat with other agents and decide what to do. But also you could have AI scribes, and this is what I've been doing with my MedChat project, where using open weight models to listen to the patient consultation and then do a summary of the consultation. So using Whisper to do the transcription, and then using a large language model to summarize it into a medical note. And the other thing that we've been looking at is doing the retraining of the open weight models using the patient data as well. So acting as a clinical decision support system. That's quite experimental at the moment. There's quite a lot of challenges with retraining the models. Some of them work quite well and some of them don't. And then the agent as well can interact with other agents in the healthcare system, for example, government agents, hospital system agents, or pharmacy, that kind of thing. So basically, yeah, the overall idea really is helping with the problem of security, access to models. Cloud-based systems can work offline. Just talk a little bit about scientific evaluation. As we're starting to see clinical decision support systems come out using large language models, it's important to note that in most countries, these would be considered medical devices and regulated like that. And there's not really been any research showing how effective they are in terms of using randomized controlled trials. There's been several thousand AI systems approved by the FDA, but very, very few RCTs of systems. Most of the authorization by the FDA is based on software saying, oh, we're similar to this other type of software, so we don't need to do a trial. And there was a trial of that other software a couple of years ago. It shows that we're kind of safe. But the FDA have not approved any large language model-based systems. There's also a wide range of protocols now for different types of study, and there's kind of increasing international consensus about what kind of things you need to report when you're writing your studies. We started a new journal called BMJ Digital Health and AI, and we're starting to publish research and editorials about using AI in digital health. So currently everything is being regulated as a medical device using the medical device regulations. So medical device regulations were set up to basically track bits of medical equipment and medical devices used by patients. So like a pacemaker is a medical device, but so is a walking stick or a hip prosthesis. So that system is really not suitable for AI, and although it's been used as a stopgap, it's likely that internationally there'll be new regulation coming out in the next year or so, thinking about how we should regulate AI seriously. So some of the discussions are, if AI is acting in an agentic way, do you regulate it in the same way that you regulate healthcare professionals? So do you make sure that it's passing exams and it's staying current and all of that kind of stuff? Or do we need to think of a new way of regulating AI? In the UK now, there's a national commission into the regulation of AI in healthcare. So hopefully we'll see the results of that fairly soon. This is just that the FDA have authorized about 1,400 AI systems. Most of these are radiology systems with some cardiovascular systems as well. But this isn't anything like, large language model clinical decision support systems. So FDA are currently just saying no to that kind of thing. there's increasing use of large language models for nefarious purposes. There's quite a nice database called the AI Incident Database. It's a bit kind of varied what they're reporting, but basically any kind of nefarious use of AI is being documented in this database. It's quite interesting to go and read, see what's going on. Increasing legal action about AI. You might have seen in the US recently, there's some large class action lawsuits going on around AI scribes and consent. So this is one way that regulation starts happening when lots of people start getting sued. It kind of sets precedents and things that can be used in the regulation. And then everyone probably has followed the situation with the new model from Claude, the Mythos model. They kind of found out that it can be used for cyber hacking, cyber warfare, really, and found lots of flaws. Briefly released it as Fable, and then the US government have locked it down, and it's not available anymore. There's various international groups looking at AI safety. Probably the main one is the UK one, AC. They did a lot of the work with Anthropic on their Mythos model. And the EU have got various rules about AI safety. And you can see from the recent executive order, the US government are looking to stop export of the more powerful models that are coming out now. Okay, that's it from me, really. Happy to have a chat about various bits of it. People can contact me on email or LinkedIn as well if they want to.
Thank you very much, Chris. And so very quickly, my part is just to show everyone sources that we use. So I think Shinji and I are referencing the open source .org website. So in this website, you can see a lot of links to the open source AI definition, the checklist, the process, the timeline, and the open weight. So I won't discuss them anymore because I'd like to leave time for discussion. What I'd like to point out is that there is this site called MOF. Are you seeing this right now? MOT dot isitopen.ai. Chuck, can you confirm that you're seeing the model openness framework?
Yes, we can see it, Dr. Alvin.
Sorry, is that yes or no?
Yes.
Yes, okay. And then when you go to this mot.isitopen.ai and then you click on evaluate model here, there is a set of forms that you can fill in. And then, by answering these questions, it will tell you whether you're actually dealing with the fully open source AI or partial open source AI or open washed AI, as Professor Shinji mentioned earlier. So I'm just sharing the URLs right now, opensource.org and mot.isitopen.ai. And I hope everyone in the call who's interested in using open source AI would understand what are the pros and cons of open source. I encourage you all to experiment with open source. It's the only way you will learn how the open source system actually works. My only recommendation is do not use real world patient data anywhere, even open source AI or proprietary AI. Do not ever upload real world data to AI. But feel free to start experimenting with this open source AI. Download them into your local devices, make experimentations, and share what you have to the community. And before I shift to the open source forum, I'd like to send an invitation to everyone in the call to join AeHIN. AeHIN is Asia eHealth Information Network. We are a group of government and non-government individuals interested in promoting digital health slash eHealth in our countries, and also invite you to the EMEA Open Source Working Group, which is headed by Professor Shinji Kobayashi. So with that, I'd like to shift to our open forum, Dr. Shinji and Dr. Chris. Maybe we can open our screens, and I have a question. Chris, my question is, uh, if I develop a fully open source artificial intelligence solution and it's available to everyone, can big tech companies, like Facebook, Meta, Google, Amazon, take what I develop and develop their use what I develop for commercial gain? Dr. Chris first and then Dr. Shinji.
I think it depends on what your license is. Like open source purists would say, yes, they can. And you should allow any use. That's what Shinji was saying, I think, wasn't it, Shinji? So you have to expect that people are going to use. One of the things quite often you get with people who set up open source projects is they're a bit horrified when people start using them for businesses and commercial reasons. And they're like, oh, I'm not making any money out of it. It's not fair that you are making money. So there's quite a lot of different business models around open source. And I think people do need to think through, how they want to make things sustainable. And some things like Moodle, which is an open source learning management system, their model is that they have trademarked the name Moodle, and that's how they make their money basically. And so there are, protect a little bit of the IP and then make it open in other ways. And I think, yeah, there's quite a lot of interesting things. I don't know for AI systems that you're developing. I think this is something maybe Shinji can talk about a bit. Is the challenge of opening training data sets, and because a lot of it is proprietary data that they train on now. So, for example, they might do a deal with publishing companies and have copyrighted data. And the other thing is the code for doing the training is quite commercially sensitive. They don't want to give away their techniques for training the systems, but then they're happy for the models, the weights to be open.
Thank you, Chris. Dr. Shinji.
Yeah. So, regulation and rules are another problem to make training for patient data or other published data. And in Japan now, we have such a privacy law under the discussing to change with permission to such a training, mass AI training, to AI training. So current Japanese regulation needs a individual permission to use for training, one training or for purpose on the purpose of it. So, but and the next challenge of the next law permits the use for such a training with regulated and condition and use for and then publish such a weight for open condition, and we can use it for and share such a trained data or open weight model for globally or domestically. What is the regulation for such a training for individual data in New Zealand or Philippines? Do you have such a regulation?
None yet in the Philippines, but we have a General Data Privacy Act, which prohibits the processing of personal information without the consent of the patient. So I guess we will go to the same path as is there individual consent for data to
Individual
be
consent.
processed beyond
Yeah.
clinical care. But before I go back to Chris and Shinji, I think we have a response from Deng. Deng is an implementer in the Philippines. She's an open source advocate. Deng, maybe you can explain your own response.
Oh yeah. I actually just messaged a few. Sorry, I can't open my video. My internet is not stable. So my answer to your question is not a simple yes or no. Because if
Yeah.
I release a fully open source AI or tech for that
Okay.
matter, the
Great.
answer depends on the license that I choose. Some open
Mm.
source licenses allow companies or big techs to use,
Oh,
to modify, and even commercialize technology. That's
yeah.
from what I know for open source. I've been an advocate for more than a decade. So, provided that they comply with the license terms, they do not need to come to me separately for permission because the license itself will grant these rights. However, they cannot just simply take the ownership of this original work or ignore the license.
Mm.
Um, if the license requires, for example, attribution, disclosure of modifications, or sharing derivative works under the same terms, then they must comply with it. So the clearer answer is that they may be able to build commercial products or services around the open source AI, especially through architecture, hosting, infrastructure, support, other services, customization, enterprise deployment. But their right to use the core technology commercially depends entirely on the license terms. Therefore, the response to that is the license is the business model.
Thank you,
Okay.
Deng.
Thank you.
Thank you, Deng.
You're welcome, Doc Eloy.
Maybe another session we can discuss it within the open source working group is ethical earning from open source.
Yeah.
Because in the end, I mean, a lot of the successful big tech companies were built
Yeah.
on open source. So, and to some extent, they say that they're actually giving back.
Yeah.
So I guess it all boils down to, like the definition of open and the licenses that we give them if you're the open source developer. And in the end, I think intellectual property uh, might be misconstrued as a bad word, but in fact, it is also a protection of the rights of individuals and of the rights of innovators. So maybe another topic, and then I request the audience if you have other topics on open source, please type it on the chat box, and we will evaluate it within the open source working group. Chris, can you just briefly talk about MedChat? Because that's what I saw from you when we met at ADB in Manila last March. You developed an AI tool called MedChat. Over.
Yeah, so MedChat is a project that we've been working on. It's kind of a small research project, really. It's based to test whether or not we can run on-device AI in healthcare settings. So the system that's been developed at the moment is on-device AI Scribe. So you can listen to the conversation and can turn it into a summary. And we're doing some benchmarking using different large language models, different hardware to see how well it performs. It's I think it's getting towards the point where it's as good as hosted models, um, but not quite there yet. And then the other aspect of MedChat is to use on-device open weight models and retrain them with the patient data from the clinic. And with the GB10 and with the Llama model, the 70 billion parameter model, you can get it to memorize the patient notes. So basically, what happens is you might use the AI scribe during the day, recording your notes, and then you have the model retrain on the notes to memorize them. And then the next day, you can talk to the model about the patients
Mhm.
and it knows what's in the notes.
It
So
remembers.
Yeah, so it's a research project at the moment, and we've got a PhD student
Mm-hmm.
working on it. We're quite interested in what the user interface for it will be,
Mm-hmm.
and want to benchmark different models and different techniques in doing it and using open source technology. So really, it's just saying there's open source technology now that can do a lot of what everyone's excited about in terms of
Mm-hmm.
AI in healthcare, and we'll be kind of publishing some papers and things soon. But
Okay.
we want to see how other people are using the same thing. It's quite simple, really. It's using open source voice to text software like
Yeah.
Whisper, and
Mm-hmm.
using large language models like Llama or
Mm-hmm.
Quen or Kimi
Mm-hmm.
or Z.ai. So there's lots to choose from now,
Yeah.
and what we want is low hallucination rate, good summarization for the scribes, and then for
Mm-hmm.
the retraining, you want verbatim regurgitation, which is when you ask it about a patient, it's like fully memorized the record. It's not interpreting it.
So this is all English right now, or have you tried it with live translation? That's the question of Navid. If the
Yeah,
consult is
no,
in an
I haven't, but I think if people wanted to try it, Naveed, I think you could do that. So it's quite straight. Like for the scribing, you just use Whisper. I know Whisper does work multiple languages, and it's what the commercial systems use as well. They use Whisper. So these commercial systems quite often just use, and they use open source models as well,
mm,
open weight models.
yeah.
So really, what the MedChat project is about is doing it on device. So doing it on your own computers, keeping the patient records private, and essentially you're doing similar to what a lot of the commercial AI scribe companies are doing.
Interesting. I think a lot of the efficiencies right now in the frontline clinical environment are the scribes. And
Yeah,
we'd like to monitor. Let us know what are updates from MedChat, Chris,
yeah,
and maybe if other people in the audience are also working with Whisper for your own local language, your own cultural requirements. Feel free to ask questions. Again, I invite you to join AeHIN. If you want to join AeHIN, just email webmaster@aehin.net. If you want to join open source working group, uh, Professor Shinji is our leader and our convener, and we will share his email address with his consent. It's not open source. We've reached the end of the hour, so maybe I'll ask the people who are comfortable to open their camera for our documentation of the people in the audience. I'm so happy to see Dr. Sheila John. Dr. Sheila, good afternoon. Good to see you again. How are you?
I'm fine, sir. Thank you very much.
Okay, thank you. Next time we will ask you to be the presenter.
Yeah, I have also done my PhD on artificial intelligence at the university. I completed it 2 years back. For diabetic retinopathy, I have worked.
Good, good. Thank you, Dr. Sheila. I'll email you for some scheduling so you can give us an update on what you're doing over there in India. So let's have a picture.
All right, thank
All
you.
right, thank you very much, everyone. Keep in touch. I will send another invitation for our next webinar. Thank you. Bye
yeah.
bye.
Bye bye.
Bye-bye.
Thank you, Chris. Thank you, Shinji. Thank you, Dr. Sheila.
Thank you.